This is Heart Rhythm TV. I'm Roderick Tung. In this month's Heart Rhythm Journal, we have a featured article coming from an analysis from CIRCA-DOSE, Prevalence and Outcomes of Atrial Tachycardia in the Cryo versus Irrigated Radiofrequency Ablation Study. We want to congratulate and welcome Drs. Christian Steinberg from Quebec Heart and Lung. Welcome, Christian.
Hello, thank you for having me.
And welcome Jason Andrade, senior author.
Thank you for having me.
Well, let's get right into this. Atrial fibrillation is the mainstay. It's the common procedure we do in the lab, and ERAF or ERAT, early recurrence of AFib and atrial tachycardia, are certainly troublesome to those patients that just undergo a procedure. Nobody likes to see this, and this is obviously a source of anxiety that we have been trained to basically reassure patients that let's wait this out for about 3 months, let the dust settle. What's really fascinating about what you're presenting here is now the continuous loop recorders data about really the prevalence, the profile of early recurrences, and also its impact on long-term outcomes. Christian, can you just tell us a little bit about why this question is important and why you believe that this is worth studying?
Well, because I think it has a direct impact on our patient management, right? When should we reablate? When should take a patient back to the lab? I think this was a little bit the major focus, to be more predictive. When is the time point when we should assume a procedure failure?
And Jason, where did the historical 3 months of waiting phase really come from? Is that really born out from data? Definitely not as rigorous as implantable loop recorders, right?
No, I mean, I think it comes from two areas. One is just people have studied early recurrences and tried to determine if there is a time point, and kind of arbitrarily it's been set at 3 months. If you look at the pathophysiological basis underlying it, I mean, it's thought that these early recurrences are due to the acute inflammatory effects of RF, the autonomic alterations that come from ablation. And people have gone back and done MRI data looking at scar maturity and positive remodeling, and shown that between 4 and 12 weeks post-ablation, that stabilizes. So there's some argument that in that 4 to 12 week period, what we have done in our ablation procedure has kind of matured to the point that nothing further is going to change.
So Christian, let's get a little bit into the methods and some of the real take-home messages for our viewership and audience.
Well, one of the major message is early recurrence of AF or atrial tachycardia is much more frequent than we think or has been previously reported, which is mostly, or which was historically biased by the user recording technology. If you use ambulatory Holter monitoring or TTMs, you will miss a lot of episodes. With a prospective monitoring using a loop recorder, you record everything.
And what you found in terms of the prevalence of ERAF was that it was actually north of 60%. Is that correct?
So 60% is a lot. This includes all episodes, symptomatic and asymptomatic. And we had a very clear definition of episodes. Every episode has been independently adjudicated. So this was a lot of episodes. I think over 35,000 events overall have been analyzed, and over 6,000 just for the early, for the first 3 months. And when you look, however, more into detail into it, and you look at it, which episodes were symptomatic and asymptomatic, we see a tremendous difference. So the majority of these episodes were asymptomatic of ERAF or ERAT. However, depending on the timing and the burden, even the non-symptomatic episodes are predictive of late recurrence or procedure failure. And the major patterns we could distinguish is those who had no late recurrence usually have a peak of ERAF episodes within the first month, and then it fades mostly away. Whereas individuals who had late recurrences have persistent events of different duration throughout the entire so-called historical blanking period.
So I think that's beautiful. And Jason, I know you want to emphasize with this figure that you're showing us right now is really this profile, kind of the wash in and wash out curves of ERAF, that they're distinctly different from those that actually suffer late recurrence.
Yeah, I mean, I think as clinicians, we've become very attuned to looking at these Kaplan-Meier survival curves of early recurrence and seeing, it's very front-loaded, the failures. But the important thing as a clinician is that when we look at how those failures happen, they fail throughout the whole time. So, we front load the recurrences because of the autonomic alterations, the pro-inflammatory effects, and all of those changes. But as those changes resolve in a month, those transient early recurrences are gone. And all you're left with for month 2 and month 3 is a distribution of continued AF episodes or atrial tachyarrhythmia episodes in those who are kind of doomed to fail with late recurrences.
And then now moving to the second figure is really the ROC analysis of where the sweet cut point is, or the optimal cut point, right, for timing to predict when it's actually an important prognostic marker. You want to take us through that a little bit, Christian?
Yes, this ROC curve shows, it tries to estimate what would be the best time point to state or that we can define a procedure failure, or where we are most predictive of late recurrence, which is actually much shorter than previously thought. It is around 20 days. This gave us pretty good sensitivity and specificity to predict late recurrence. So roughly 3 weeks compared to the historic 3 months.
So take home points for me are, one, using a loop recorder really tells you there's a lot of asymptomatic, and the prevalence is much higher than we typically tell patients, maybe 30 or 40%. ERAF, this is much higher, it's north of 60%. And the symptomatics are actually predictive still. The other take home for me is that the profile in terms of the frequency of how it kind of washes out and how they go away is really predictive as well. So let's talk about pragmatic. Jason, does this change the way you're going to be practicing, and should it change clinical practice? Should we be intervening a little bit sooner and calling it a failure earlier within a month or two?
Yeah, so I mean, I think there's different elements to the conversation. I mean, the other figure that's in the paper that we didn't talk about here is we did the same ROC analysis looking at burden. So it's no longer about timing, but it's about how much arrhythmia people have. And you can use that information. The problem for me as a clinician is if I have to wait 90 days to look back at the burden over that period, it doesn't help me plan. So the analysis that we showed, or we're showing here, is looking at that episode in front of you today. So if that patient presents to hospital on day 50, I know with a 94% specificity that patient's going to have a true failure. And I can use that episode on that day to plan future intervention. And so if I have a 95% chance of being a true failure, that argues that I need to be more proactive as a clinician at trying to improve that patient's outcome. Now, strictly speaking, I can't say that early intervention is necessarily warranted because that wasn't studied, that wasn't part of the protocol. But we have done previous analyses within the STOP AF data set that we published maybe about 8 years ago that showed that patients treated with reablation in the blanking period had better long-term freedom from recurrent AF than patients who had no early recurrences. So, there are similar data sets out of other studies that suggest that earlier intervention in month 2 or 3 for those later recurrences in the early blanking period may improve outcomes for our patients.
Well, I want to congratulate both of you on a really fine study from CIRCA-DOSE. Jason, you know how I feel about the introduction of loop recorders in CIRCA-DOSE and randomized clinical trials. I think you've set the new standard. It should be the gold standard. The bar is up here, and we know that any trial that's done without continuous loop recorders has limitations. And I think this again highlights the fact that we're missing a lot of these asymptomatics and they're relevant clinically. So thank you very much. We know that this is going to be the subject of multiple journal clubs across the country, across the world, and people will be actually tuning in to the actual manuscript and reading all of it in its entirety. Congrats again, and thank you for joining us on Heart Rhythm TV.
Thank you for your support.
Thank you very much.